Hydration and IV Therapy, Part 8, Iowa Lakes Community College, Martha Olson. Our older adults then have special needs with IV therapy. We need to consider their small, fragile veins are very easily damaged, so look for a vein that allows for maximum mobility and encourages their movement. A big part of IV therapy is watching for vascular overload. A little bit of congestive heart failure, decreased heart function with pumping, or decreased renal function can very easily put them into overload. So as you're thinking about watching for the IV site, listening to the lung sounds, intake and output, watching for edema, all of those things are needed when we are monitoring the older person for vascular overload. Their thin skin, we need to really watch for breakdown, make sure we're taking the tape off carefully, not using excessive amounts of tape that when removed cause skin tears, and our use of the stretchy co-band can constrict on the skin, so we need to use that consideration also. Because of decreased cognition, we have to explain things perhaps a little more slowly or thoroughly, and with the decreased vision and hearing, we think of safety. Pushing an IV pole down the hall could cause them to trip. When we think about the decreased immune system, we know they're at risk for infection, and so we want to check those IV sites perhaps a little more often. For our tourniquet, because their veins are very fragile, the tourniquet may not be necessary. Sometimes you can get the veins to pop out a little easier on an older adult, or another trick that works a little better sometimes than the tourniquet that can cause skin issues is to put a blood pressure cuff on and just pump it up gently to get your veins to pop out. If the veins are distended without the use of a tourniquet, then don't use one, or like I said, the light tourniquet or an IV blood pressure might work as well. After applying a tourniquet, do the procedure as soon as possible. The tourniquet on that skin too long can cause problems for them. Our fluid overload, again, remind you to watch your lung sounds, intake and output, neck vein distension, respirations. O2 sats can even tell you about fluid overload for them. We watch for phlebitis and infiltration. Remember to know your signs and symptoms of phlebitis versus an infiltration. Phlebitis is warm to touch, infiltration is cool to touch. Your hematoma is going to be hard when you palpate, and your infection is going to possibly even go systemic, where it causes an increased white blood cell and the lethargy that they feel. To prevent infections, remember we change our IV site every 2 hours as per protocol. When we look at the legal aspects of that, nursing is ever changing, and it is our responsibility as a nurse to stay current with what is going on. Know your state laws before you practice any of your IV therapy, what can be done, and then as we look at these standards to deliver safe and consistent care, we know it's only there to protect the public and give them quality care. If you're ever involved in litigation, you need to be able to say without a question the time that you inserted it, the site that you chose, and your best defense for that then is going to be documentation that is carefully and correctly completed. This is Objective 79, where we look at the legal responsibilities of the RN with IV therapy. When we look at the legal responsibilities, we know that assessing early for infiltration and phlebitis, it doesn't mean that we're always going to prevent it from happening, but if we're observing often, we can get those things, the IV, discontinued as quickly as we notice the problem starting before it becomes a big problem. Nerve injury is another legal risk that we can think about with extravasation, or the burning of the tissue into that compartment. They might feel numbness and tingling, and those would be things you would want to check out if a patient complained of them. Giving the wrong drug, so again, following your triple check, your 6 rights of drug administration to make sure that we are doing what we should be doing. If you don't have a lot of experience starting IVs, it just takes doing it. It takes trying it and not getting them, but watching experienced nurses and not ever being afraid of doing them, because you eventually get better and you kind of get the hang of how it is done. Infusion of foreign objects can be such things as air, and so we want to make sure that our tubing is primed and we aren't giving them any additional complications. We want to make sure we know our anatomy and physiology, so we're avoiding any bifurcations, any valves, those types of things, and doing them correctly. Clarify any orders, know what drugs you're giving and how fast they can be given. If you're not familiar with the antibiotic that's ordered IV piggyback, you would want to read in your drug book and know how fast it should be administered, and then assess and monitor your patient for fluid overload, any problems with the IV medications that are being administered, any numbness or complaints to that extremity. We treat our complications appropriately, following protocol, remove the IV, warm pack, elevate, make an incident report, and then stay current and knowledgeable with the Nurse Practice Act and the policies and procedures. Years ago, we used to flush everything with heparin, but our research has told us that that is not the best, and so now we just flush today with saline. When we think about some areas of patient assessment, we want to think about food and drug allergies, environmental factors. What age are they? Their gender, lifestyle, maybe the amount of adipose tissue or any other pre-existing conditions that they might have. Our main dangers of giving anti-infective medications over prolonged periods would be hypersensitivities, superinfections, and bacteria that become resistant to the medications that we are using. With our evaluation, we want to make sure we are properly hydrating our patients and watching our sites to make sure that they are safe and not getting infected or infiltrated. Situations we want to think about for this unit, when we look at our IV antibiotics, is there a peak and trough that goes with that order? When was it started? How many days of IV antibiotics? When will they be going home? Are we switching them to oral antibiotics? Are such things that we need to think about. And with our special considerations then, our children or pediatrics sometimes have a hard time keeping that IV, and they pull them out as quickly as you can put them in, so we have to sometimes think of alternative sites like perhaps the foot. It's hard to tell with their little pudgy extremities when they are infiltrated, so that can be a challenge. That's where I would recommend you put a syringe on and pull back and see if you get good blood flow or blood return into your syringe. Our drips are always slower, and we perhaps will use the 60 drop tubing with the pediatric population. A couple of situations that I would think about as you're studying for this that go along not only with the hydration or IV, but also with the hydration. A patient is eating well, eating 100% of all meals, taking fluids well, no nausea, vomiting, or diarrhea. Your assessment is they have a blood pressure of 130/80 and a pulse of 80. Their skin is warm and dry with no tenting. Mucous membranes are moist. Urine output is 1,000 milliliters in 12 hours, and your IV is running at 125 an hour. This patient is well hydrated. In that scenario, you would want to be thinking, why is the IV still infusing? If they're drinking, they have good urine output, and there's no problems with the vitals. Our second patient to think about is one that has recently had abdominal surgery. Your urine output is 300 milliliters in 12 hours. You have tenting of the skin. Your blood pressure is low at 92/60. They have a pulse of 118. No bowel sounds. They remain NPO or nothing by mouth because the bowel sounds are absent, and their urine is a dark concentrated color. Would that patient still need IV fluids? I would say the answer is yes, and if the doctor does not have IV fluids, you would want to question that because the patient has NPO, so they're not getting anything in orally, and their urine is 300 mils in a 12-hour shift, and we know that does not meet the rule of 30 mils per hour. And our last patient that we're going to think about for proper IV, or should the IV be continued, is your patient with Crohn's disease. They have malabsorption of food. They've had diarrhea for 10 days with their Crohn's disease. Their pulse is thready. Urine is dark amber. It has not been measured because the patient gets himself up to the bathroom. Your intake for the Crohn's patient has only been sips of 7-Up and a little bit of water. There's no edema noted. The color of the skin is pale. The skin is very fragile and thin. As we think about continuing with this patient, IV fluids would definitely need to be continued because of the diarrhea for 10 days, the tenting. The intake is only sips of water, which is not adequate, and the urine is dark amber. The thready pulse comes from the hypovolemia, and I would also tell the patient, I'm putting a hat in your room. We need to measure your urine output at this time so we can get a better idea of your hydration status. Getting a daily weight would be a great nursing intervention without an order, and you might also just consider and have the doctor consider would TPN. If this is a patient with Crohn's disease, they have malabsorption issues and we're resting that small intestine where the absorption takes place, that might be a patient that would qualify for a PIC or a central line and get TPN to get them hydrated and back up to speed for nutritional balance. So just a couple of situations to think about as we look at change in vitals, change in assessment with skin, urine output, tenting, mucous membranes, and is the IV that is running appropriate, or if they don't have an IV, is one needed, or do they have an IV and it's not needed? So we start thinking about that because in basics you will do your big IV unit, and soon you'll be in the lab with your IVs and doing some scenarios with that as well. This ends the 11-hour IV unit. We will be doing some clicker questions, some IV math, and some application in class. I'll see you then. Thank you.